I see our numbers are getting close to 100. So again, thanks to all of you for joining us this morning. I'm going to get started in the interest of time and to be respectful with everyone who's been here on time. Good morning, everyone. For those of you who don't know me, my name is Alejandra Rincon, and I serve as Assistant Vice Chancellor for the Office of Diversity and Outreach, the sponsor of the 14th Annual UCSF Healthcare Disparities Research Symposium. Again, thank you all for being here this morning. Can I get a thumbs up that someone can see me and hear me well? Or can you see me and hear me well, my team? Just doing a quick check-in aside. Yes, okay, excellent. All right, thank you. So I'll carry on. I want to begin by thanking all of you for making the time to be here over these 2 days to learn, discuss, and advance key topics about healthcare disparities. Despite all of the current scientific advances, many of which are taking place right here at UCSF, underrepresented groups continue to be excluded and medically marginalized. Forums like this take on a special significance. They remind us of the need to ensure that the clinical, research, and educational missions of UCSF be open to all. And this symposium is certainly a highlight of UCSF. The wide variety of research being conducted across campus and across disciplines is critical to addressing healthcare disparities. The COVID-19 pandemic brought the terrible price of these disparities onto the national stage. This has led many scientists and healthcare leaders to strengthen our resolve, redouble our commitment, and work with a greater sense of urgency. However, the people presenting today and those who presented yesterday have been working with resolve and a sense of urgency for years. Their commitment to equity in research, patient care, and access is longstanding. I hope you find all of them, the panelists, poster presenters, and our hosts, as illuminating, inspirational as I do. They're helping us create a more just, equitable, and healthy world. Yesterday's sessions and certainly the keynote were wonderful, and I'm pleased to tell you that we have another full agenda of groundbreaking science for you today. If you missed anything yesterday, we're recording all of the sessions for posting online after the event. Please visit the Office of Diversity and Outreach website to access the recording links. By the way, October is UCSF Diversity Month, and you can find educational, celebratory, and community building events on our website as well. I would also like to remind you all to participate in the UCSF Climate Survey, which is going on right now and just kicked off earlier this week on Monday. Your opinions about the culture of our campus will help us create a more inclusive UCSF, a place in which we can all study, work, and research while feeling like we belong. So check your email and take the survey. We would love to hear from you. In closing, I would like to extend my gratitude to the team that comes together and makes this event possible and has made it possible for so many years now. Thanks to Dr. Tong Weng, Victor Fujimoto, and Jane Ji for volunteering their time to put this program together, as well as the faculty who assisted with the reviews of the abstracts and the posters. Just as importantly, I would like to thank the staff of our office, and in particular, my special gratitude to Andrelyn Rivera for her work in making this event and past years a total success. Thanks to also all of the presenters and to all of you as attendees who make time to join us today. I truly believe that if we come together with science and conscience, we can create a healthier existence for all. Enjoy the day. And with this, I pass it back to Dr. Tong Weng. Thank you.
Thank you, Dr. Rincon. Welcome, everyone. Welcome back for our second half day of the UCSF 14th Annual Health Disparities Research Symposium. My name is Tong Weng, as Dr. Rincon said, and I'm a member of the Planning Committee. A quick recap from yesterday. We had Chancellor Hallgood announce some exciting new investments in health disparities and equity research at UCSF. 3 great plenary presentations, 5 breakout groups with diversity of excellent research, and an inspirational and instructive keynote by Dr. Camaro Jones. Today, we have for you 2 plenary sessions with 6 breakout sessions in between. We hope that you will be around for both plenary session and check out at least one of the breakout sessions. As a reminder, all of the breakout posters are available online at epostersonline.com/HDRS2021. Please help us improve the symposium for the future by doing the evaluation when it is sent to you electronically. If you attended yesterday, the evaluation was sent yesterday. There is one for yesterday and for today. It will be separate. So without further ado, we will start today's first plenary session. There are 4 presenters. Each presenter will give their presentation for 10 minutes or so, and then we will have 20 minutes for questions and answers at the end. Feel free to type in your questions as they come up in the question and answer box, the Q&A box on your screen. But do preface the question with the name of the presenter so we know who to direct the question to. If we have too many questions to respond to verbally, I encourage the presenters look at the later ones toward the end of our session and answer them via the Q&A box. So first up is Maren Scheuner of the School of Medicine, presenting on unintended consequences of a specialty care telehealth program, an intervention to increase access to genetic services, exacerbates healthcare disparities. Dr. Scheuner.
Good morning. Can you hear me okay?
Yes.
Wonderful. Thanks so much for the invitation to speak with you today about our research conducted at the VA. The title of my presentation is Unintended Consequences of Specialty Care Telehealth Program, an intervention to increase genetic access to genetic services exacerbates healthcare disparities. Full disclosure, I'm not a health disparities researcher. I'm a clinical geneticist and health services researcher at the VA. Ever since I began my career almost 30 years ago, I've known that genetic services are underutilized, and I'm passionate about understanding why that is and how to improve access so that everyone can benefit from the promise of genomic medicine. I have nothing to disclose related to this presentation. However, as a federal employee, it's important that I state the views expressed are my own and don't represent those of the VA. And the research I'm presenting was funded by the VA. Oh, sorry about that. It's advancing, and I didn't mean to do that. Limited access to genetic services is a widespread problem. Research suggests there are not enough genetics providers to meet the ever-increasing demand. A recent survey of consumers found they can't find providers with expertise in their genetic condition, especially adult patients. And further complicating things, most genetics providers are located in academic metropolitan settings, and patients can travel very long distances to see a genetics provider. And frontline clinicians are not prepared to take up the slack. They have gaps in knowledge about genetics and genetic testing and how to communicate genetic information to patients. Telehealth is viewed as a potential solution to improve access to genetics, but the impact on care coordination, equity, and quality of care is unknown. Telehealth enables the delivery of healthcare across long distances, extending the reach of specialized expertise like genetics, and the use of telehealth by genetics providers has increased in the recent years and has become the predominant mode of delivery during the pandemic, and it's likely this is going to continue. Centralized telehealth genetic services have been created by medical corporations, academic institutions, and the VA is probably one of the first institutions to create a centralized service back in 2010 with the goal to improve access nationwide. The objective of our research was to understand how a centralized telehealth model influences care coordination of genetic services compared to other available care models. We didn't set out to examine disparities, but we uncovered evidence of this that I'll describe to you this morning. We conducted a retrospective observational study of patients referred for genetic consultation in the VA from 2010 to 2017 with 2 years of follow-up. We studied 3 genetic healthcare models available in VA: the telehealth model, comprised of a centralized team of counselors serving VA facilities to about 80 VA facilities nationwide. The traditional model in VA comprised of regional services provided by geneticists and genetic counselors locally and to a few VAs nearby. And the traditional model in the community, which is purchased by VA when services are not available within the VA. We used multivariate regression models to assess associations between patient characteristics and consult characteristics and the outcomes of referral to the type of genetic care model, completion of consults, and having 0, 1, 2, or more cancer surveillance or risk-reducing procedures within 2 years of the consult. We also included interaction terms to examine the moderating effects of demographic and other variables. The next two slides I'm going to show are the patient and consult characteristics of our data set. In red font, I'm showing where there are differences between the three care models. We found 24,778 patients with a genetic consult. Most, about 60%, were referred to the telehealth model. About half were age 50 or older, and about half were women, even though women comprise only 10% of the VA population. About 60% were white, with more white patients referred to the telehealth program. Overall, 71% of patients completed their genetic consult. However, only 57 completed their consult if referred to that non-VA care model in the community. The median number of days for completion of a consult referred to non-VA care was almost 3 times longer than observed with the VA, either VA model. Referral to the 3 models grew substantially over the years, with larger proportions received in later years for the VA telehealth and non-VA care models, and cancer was the most common reason for referral. In the next few slides, I'm going to review the findings from the multivariate logistic regression models. Here, for the outcome of referral type, we found that compared to the traditional model, referral to telehealth was more likely for women, married patients, patients with health insurance, and cancer-related referrals. Patients were less likely referred to the VA telehealth model if they were Black, especially Black men, but we saw the opposite for Black women. They were also less likely referred if they were Hispanic patients and patients of other races, or if referred for gastrointestinal disorders or cardiovascular connective tissue disorders. We found patients were more likely to complete their consult if they were older, especially older women, if they had a service-connected disability, or if they had health insurance. Patients were less likely to complete their genetic consult if they were Black or of other races, if they were referred to the VA telehealth model, particularly Black patients referred to the VA telehealth model, or if they were referred to non-VA care. Again, except for women referred to non-VA care who were more likely to complete their consult. And then the last outcome, looking at multiple cancer surveillance and risk-reducing procedures in 2 years following the consult, we found patients were more likely to have multiple procedures if they were older, if they were women, especially younger women, and if they were Black or Hispanic, if they had service-connected disability, or if they were referred for a GI disorder, or if their consult was completed, which suggests an influence of the genetic consult on uptake of these preventive procedures. But this was only true if the patients completed their consult with the VA traditional model. Patients were less likely to have multiple cancer surveillance procedures if they reported as an other race or other than white, Black, or Hispanic, were referred for neurology or psychiatric conditions, or if they were referred to VA telehealth, especially older or female patients, or if they were referred to non-VA care. So in summary, we found that the VA genetic care models have better care coordination than non-VA care. These results are similar to other studies examining VA versus non-VA care. We found genetic services are highly relevant for women who are overrepresented among patients referred, especially to the VA telehealth model. And we found that VA telehealth model exacerbated healthcare disparities based on race, ethnicity, gender, and age. On this slide, I'm reviewing some of the possible explanations for the healthcare disparities we observed with the VA telehealth program. However, it's important to note that with our observational design, we can't address causality, and additional studies are warranted to better understand our findings. First, the centralized structure and uniform approach of the VA telehealth model may improve certain efficiencies in care, but could challenge care coordination by constraining the ability to tailor services, stifling initiative and innovation, and complicating communication processes. Also, vulnerable subpopulations may be less able to benefit from the centralized approach due to inconsistencies between the social and cultural assumptions of those developing and implementing that approach and the population served. There may be biases of referring physicians regarding perceived preferences of non-white patients for the VA traditional model, or non-white patients may have declined referral to the telehealth model. And studies have shown Black patients rate visits with healthcare providers as less participatory than white patients. Thus, the VA telehealth model may be perceived as a barrier that complicates patient-provider communication. Studies have also shown that Black and Hispanic individuals have mistrust of the medical community in general, and concern of potential misuse of genetic information specifically. And then lastly, with regards to women being more likely referred to the telehealth model, this may be due to preferences to avoid the VA traditional care model based at VA medical centers because of harassment experienced by some women at certain VA facilities. On this slide, I'm showing that there are many spheres of influence on genomic medicine implementation. Our results make clear the importance of planning for implementation of a healthcare intervention, and we need to be mindful about introducing inequities that can span the various levels of influence and that could exacerbate healthcare disparities. Eva Woodward is a health disparities researcher in the VA, and her work has helped us to understand our findings. She's created a health equity implementation framework to provide researchers and practitioners with tools to guide implementation and mitigate disparities. She's described 3 health equity domains that can inform implementation, including cultural factors of individuals, the clinical encounter of patient-provider interaction, and societal influences. On this slide, I'm showing how the equity framework domains in purple, blue, and green map to our possible explanations of why we observed healthcare disparities with the VA telehealth model, and we see all 3 domains are represented. So in conclusion, what I've learned from our research is that inequities can occur at multiple levels in healthcare delivery. Implementation frameworks can help plan for and evaluate interventions designed to promote access to and utilization of genetic care. And implementation science theories, methods, strategies, and evaluations that include equity domains can help to ensure effective interventions reach the people they're designed to help. I'd like to thank all of my co-investigators and VA Central Office for funding this work. I have a list of references here for you, and I want to thank you for your attention and look forward to questions and comments. Thanks.
Thank you, Dr. Scheuner. Just as a reminder, if you have any questions, please put your questions in the Q&A box with the presenter's name, and we'll get to it after all presenters are done. Next up is Sara Zhou of the School of Medicine, presenting on effectiveness of opt-in versus opt-out text message-based outreach for colorectal cancer screening.
Thank you so much, Dr. Nguyen. Hi, everyone. Again, my name is Sara Zhou, and my research has been on describing and evaluating a colorectal cancer screening campaign that was using opt-in and opt-out text messages for outreach. I'm here representing a larger team that consists of my mentor, Dr. Ma Simsa, as well as the San Francisco Health Network's Population Health and Quality Unit. So colorectal cancer causes really significant cancer-related morbidity and mortality in the United States, with about 150 estimated new cases and 53,000 deaths in 2021 alone. However, we know that colorectal cancer is preventable through early detection and treatment. And this can be through visual exams like colonoscopy and sigmoidoscopy, but it can also be through stool-based exams that check for occult blood in the stool. We also know that the burden of colorectal cancer is not equally distributed amongst populations in the United States. For example, we know that patients who are uninsured or ethnic minorities present with more advanced stages of disease. And this is in part due to the fact that screening is underutilized, especially in vulnerable populations. And so as a result of the huge burden of colorectal cancer, the National Colorectal Cancer Roundtable set a goal to screen 80% of communities across the United States. However, these screening goals were completely shattered by the pandemic. And this was because between February and May of 2020, we saw in the healthcare network that there was a huge scale up of telehealth care, which led to an overall decrease in in-person adult primary care visits, as well as cancellation of all non-urgent endoscopic procedures. So as we can see in this graph, as we increase in telephone visits, we decrease in colonoscopies, as well as FITs, or fecal immunochemical test, which is one of the stool-based fecal occult blood tests that I mentioned before. So this corresponded with an overall decrease of between 85 and 90% of all colorectal cancer screening in the San Francisco Health Network. So this really forced us to consider how to better organize colorectal cancer screening efforts. This is because screening is usually a process that occurs in person when a person goes to their primary care physician. The physician notices that the person is overdue for screening and makes an appointment or referral for screening in the office. So we had to determine a way of reaching people when they're not coming into the office at all. And so we know from other studies that proactive outreach by the health system, and particularly mailing colorectal cancer testing kits directly to people's homes, increases screening uptake. So for example, this RCT that was done in the San Francisco Health Network showed that population-based management of colorectal cancer screening, including advanced notification phone calls, followed by mailed fit kit outreach, really significantly increased screening uptake by 21 percentage points. However, because there were limited resources with the pandemic and there was also this urgent need, it was really difficult to determine what the cost and labor would be like for a similar outreach effort using telephone screening. So in response, in November 2020, the San Francisco Health Network's Population Health and Quality Unit launched another colorectal cancer screening campaign using text message-based outreach instead, which has the potential to be low cost, easily scalable, and can be delivered instantly. So they use the automated text message platform, CareMessage, to send advanced notification text messages, followed by mailed fit kits to improve screening uptake within the San Francisco Health Network. The initial goal of the intervention was to use PDSA cycles to preferentially reach out to Black and African American patients by asking them if they wanted to opt in to receiving a mailed fit kit. But due to low response rates initially, the intervention was expanded to include all demographics. Furthermore, as a result of the initial low response rates, the Population Health and Quality Unit made the decision to test opt-in versus opt-out messaging for effectiveness at increasing screening uptake. So opt-in messaging, which is how colorectal cancer screening is usually done, requires explicit consent of the patient to participate. However, opt-out messaging, which has been shown in the past to increase uptake in flu shots, organ donation, and cancer screening, already assumes consent and just gives the patients the options to not participate. So for example, an opt-in text message would sound like, we would like to send you a free at-home colorectal cancer testing kit. Please text yes if you would like to receive a kit. And an opt-out message would sound like, we will be sending you a free at-home colorectal cancer testing kit unless you text back no or stop. So by adding all of these layers together, the overall intervention was the following. So first, patients were recruited from 11 adult primary care clinics in the San Francisco Health Network, initially targeting Black and African American patients. These patients who were overdue for screening were assigned to receive either opt-in or opt-out text message-based outreach. And then the patients were mailed fit kits if they either opted into receiving them or did not opt out of receiving them. And finally, we have evaluated the effectiveness of the campaign by looking at screening uptake at 3 months after initial outreach. And we did this by looking at fit screening status in the electronic medical record. And so our patient population included patients who were between 50 and 75 years old and had been seen in the last 24 months at one of the primary care clinics in the San Francisco Health Network. They were overdue for screening based on the USPSTF guidelines. So that's FIT 1 year ago, sigmoidoscopy 5 years ago, or colonoscopy 10 years ago. And they also had a previous history of FIT completion. And here are some of our exclusion criteria, which I won't read off just now. And so these are results. This is the patient demographics divided by intervention arm. So overall, we recruited 522 patients for the opt-in arm and 371 patients for the opt-out arm. And we did notice that there were some differences in the demographics of each intervention arm. So in red, I've highlighted some of the subgroups that are traditionally associated with lower compliance of screening. And then in green, I've highlighted some of the groups that are associated with higher compliance with screening historically. And so we can see in this table that there is a slight overrepresentation in the opt-in arm for patients who are male, who have English as their preferred language, who are of Black or African American race, and have Medi-Cal insurance. And then in the opt-out arm, we see that there's slight overrepresentation of patients who are female, who have Chinese as their preferred language, are of Asian race, or have healthy workers insurance. And so we think that these sampling differences were likely due to unequal sampling of the different clinics within the San Francisco Health Network, as well as a shift in strategy from focusing just on screening Black and African American patients using opt-in outreach to opening up screening to all demographics with opt-out outreach. And so overall, we were able to send fit kits to 96.5% of the opt-out arm and 19.3% of the opt-in arm. And our major finding is highlighted up here at the top of this table, where at 3 months after initial outreach, 18.0% of the opt-in arm patients were up to date with screening. And then 58.8% of patients in the opt-out arm were up to date with screening. So this means that opt-out text message-based outreach was significantly more effective at getting people screened than opt-in outreach, with an odds ratio of 6.49. And we also wanted to take a look at all of the different subgroups of the demographics because, again, there were some differences in the sampling, as was mentioned in the previous slide. And we see that there's generally a similar trend for most of the subgroups. So in the opt-in arm, we see between 15 to 20% of patients up to date with screening at 3 months. And then screening uptake in the opt-out arm for most subgroups is about 50 to 60%. However, there were some subgroups that had significant differences. For example, we see in the preferred language subgroups, Chinese language was associated with increased screening uptake with 57.1% in the opt-in arm and 63.6% in the opt-out arm. And furthermore, healthy workers insurance was also associated with increased screening uptake with 26.7% in the opt-in arm and 66.7% in the opt-out arm. However, when we look at race specifically, we see that Black or African American patients have consistently lower screening uptake results, regardless of whatever intervention they were in. So in the opt-in arm, 9.4% of patients were up to date with screening at 3 months. And in the opt-out arm, 33.3% were up to date with screening. So this means that there is still a disparity that exists where African American patients are still receiving low screening rates despite whatever outreach interventions they receive. So there's more work that's needed to bridge this disparity. And so in summary, the COVID-19 pandemic provided unique challenges to colorectal cancer screening due to historic reliance of in-person opt-in screening. However, we found that advanced notification text message-based outreach, followed by mailed fit kits, was an effective method at increasing population-level colorectal cancer screening rates in the San Francisco Health Network. We also found out that opt-out messaging was significantly more effective at increasing screening rates over opt-in messaging. And finally, tailored initiatives are needed to address low screening rates for Black and African American patients. And I just want to thank my co-authors as well as the organizations listed on this slide. And then I also have some references. Thank you so much for listening to my presentation.
Thank you, Sarah. Again, questions in the Q&A box. We'll get to it after the end of all the presentations. Next up is Fiona Ng, School of Medicine, presenting her abstract titled Examining Tobacco Cessation Within the Context of Diet and Physical Activity Changes Among Chinese and Vietnamese Smokers and Their Families.
Good morning, everyone. Thank you for the opportunity to share my team study with you all today. Let's first take a look in the burden of tobacco use among Asian Americans. If I can take your attention to the chart on the bottom, when we look at Asian Americans and Pacific Islanders as an aggregated group, we see that according to the CDC, 7.2% of Asian American Pacific Islanders use tobacco compared to the US population in general of 14%. While that may look like it's lower, aggregated data oftentimes mask the true burden of tobacco use among Asian American communities. Instead, we should strive to look at disaggregated data as well as examining intersectionality, such as by ethnic subgroup, gender, and language. So for example, when we look at Chinese men in California with limited English proficiency, we see that the tobacco use burden is actually much higher than what the aggregated value is suggesting. In addition, Asian Americans are also facing many barriers at multiple levels when it comes to tobacco cessation, such as at the structural and system level of targeted advertisement, interpersonal level, being less likely to receive any counseling on tobacco cessation from their health providers, but also at the individual level, having concerns regarding nicotine replacement therapy. While tobacco cessation interventions such as nicotine replacement therapy and counseling is the quote unquote standard of practice for many and for a lot of Chinese and Vietnamese smokers, we may actually be in need of an alternative or intervention or something to help supplement us to these standard of care. Another way to think about tobacco cessation is to look at it in the context of multiple health behavioral change. And by multiple health behavioral change, these interventions focuses on changing behaviors, two or more behaviors from different domains. So for example, physical activity and tobacco cessation. At the individual level, for multiple health behavioral changes, there have been studies that have looked at the relationship between smoking cessation, physical activity, and diet, but all of the studies have had very mixed results in terms of how they may be related, if they enhance each other or make it harder to achieve one of the three behaviors. We can also look at multiple health behavioral changes at the level of dyads or at the family. In studies, they have found a high level of concordance for health behaviors within the same domain between couples or dyads. So for example, both individuals becoming more physically active over time. However, there's less of a consensus when it comes to looking at concordance between dyads across domains of behaviors. So for example, does one individual changing their diet tell us anything about the other individual's physical activity trajectory? So this led us to ask two research questions. The first research question is at the individual level of multiple health behavioral changes. Does changing one's diet or physical activity predict smoking cessation success? And what about at the dyad or family level? Does family member changing their diet or physical activity predict anything about the smoker's tobacco cessation success? To answer these questions, we conducted a secondary data analysis of a randomized controlled trial. In this randomized controlled trial, there were 340 dyads. In the dyad, there was one individual man who smoked every day and a non-smoking family member. These dyads received a lay health worker-led health education series as a part of the intervention. All the dyads were were randomized into two different groups. They were either in the tobacco cessation group or the healthy living group that focused on teachings regarding healthy eating as well as physical activity. All of these sessions were conducted in person, in Cantonese or Vietnamese, and led by lay health workers who are themselves from the communities of these participants who did not have any medical training prior to this project. On the bottom here, I wanted to showcase some of the teaching resources that were used by the lay health workers. This is a flip chart to facilitate these teaching sessions, as well as helping the family members come together to develop action plans. In addition to attending these education sessions, these smoking participant and the family members also completed a series of phone surveys. In these surveys, they were asked questions regarding demographics, as well as smoking, physical activity, and their diets. My secondary data analysis focused on the survey responses at baseline, 6 months, and 12 months. For our statistic testing, we use bivariate and multivariable logistic regression analysis using generalized estimating equation to account for the lay health worker clustering. When it came to the outcome variable, we were interested in tobacco abstinence and specifically the 7-day abstinence at 12 months as reported by the smoking participants themselves. This variable was also verified by what the family's response were at 12 months regarding their family members' smoking status, as well as the smoking participants' saliva cotinine level at 12 months. Of note, in the primary randomized control trial, they found that the abstinence rate at 12 months, which was 24.4%, was actually not different by the by the treatment groups. Next was the defining independent variables in our study. We were interested in looking at the predictors, which were the changes in diet and physical activity over from baseline to 6 months for our participants. And specifically in our study for diet, we were looking at whether the participants met my plate recommendations over this time period, which was if they were eating 50% of their meals consist of fruits and vegetable. For physical activity, we defined it as whether the individuals were able to exercise for 150 minutes or more within a week. Each of these participants were then categorized into 4 groups based on the trajectory of change in these respective behaviors, diet and physical activities, into 4 different groups. So for example, for diet, they were divided into never met the recommendations, stopped meeting recommendations at 6 months, started to meet recommendations at 6 months, or continued to meet recommendations at baseline and at 6 months. For covariates to be included in our final model, we used bivariate analysis to determine which variables to be then included in our multivariable logistic regression model. And all the variables here listed in red were the ones that we ended up including in our final model. Here I wanted to show a figure that re-examines our research question. In the center is our outcome of interest, which was smokers at 12 months, their tobacco abstinence. And then our predictors up on the side here, for the smoking individual, changes in their physical activity, changes in their diet. Does that tell us anything about smoking at a later time point? And similarly for the family's changes in diet and physical activity, does that tell us anything about the smoker's tobacco cessation at 12 months? So for results, let's get to know our participants a little bit more. In this randomized control trial, and as well as our secondary data analysis, there were a total of 340 smoking participants in the study. They were all men who were smoking every day at the time of recruitment. Half of them were Chinese and the other half of them were Vietnamese. And 97% of our participants spoke limited English. And for at least 40% of them were of lower income and had less than high school education. On average, our participants who smoked were smoking for 28 years and reported 62% of them reported that they were not confident in themselves quitting smoking within the next 6 months. And for our family participants, they share very similar demographics, with the exceptions being that 93% of them were women and they were not smoking at the time of recruitment. They were the partners, siblings, children, or parents of our smoking participant. This slide shows 2 graphs to demonstrate the distribution of our participants into the 4 different behavioral change groups. And on the top, we have the smoking participants distribution. You can see the 4 groups of continue to meet, started to meet, stopped meeting, as well as never met the nutrition in the stripe bars, as well as the physical activity groups across the 4 groups. And on the bottom, we have the family participants distribution. As you can see that there's a wide distribution between the 4 groups in terms of how their behaviors change within these 0 to 6 months. And what was the ultimate finding of our study and what were we really looking for? What actually predicted smoking abstinence at 12 months? So in our multivariable logistic regression model, what we found was that both the smoking individual, their changes in diet, as well as the family member's physical activity level, both predicted smoking abstinence at a later time point. More specifically for the smoking individual, compared to those who never met these guidelines, those who started to meet at 6 months had a higher odds of achieving abstinence. And then for the family members, those smoking individuals who had family members who continued to be physically active throughout this time point, they were also had higher odds of achieving abstinence. This is, again, just another graphic representation of our findings. So in conclusion, what we found in our study was that healthy diet and physical activity at both the smoker as well as their family members individually predicted smoking's cessation success. Therefore, examining tobacco cessation within the context of multiple health behavioral change at both individuals and dyadic level may yield a promising intervention for Chinese and Vietnamese Americans who often have high burden of tobacco use, but is masked by the aggregated data. And even though in our study, we really focus at the individual and dyad level of behavior change, it should not be forgotten that it is important to address the inequities and structural determinants of health when it comes to what will really be facilitating these behavioral changes. For example, future studies should really think about, in the context of multiple health behavioral change, who's making the policies and which communities are affected by policies that determine who gets access to safe recreational spaces, healthy food, as well as being free of targeted advertisement from tobacco companies. Future studies should also examine mechanisms behind multiple health behavioral changes. In our study, we weren't able to identify those, but I would like to end with a quote from one of our participants who not only summarizes our study, but kind of shines a light on what may be explaining the mechanism behind multiple health behavioral changes. So from one of our Healthy Living Group participants, the project was good. The time attending the project was short, but I gained a lot of knowledge. I know how to eat healthily and do physical activities. I decided to quit smoking. And with that, I would like to thank all my mentors who helped guide me in this project, as well as everyone that was involved in the primary study, especially the lay health workers, the participants, and our community organization partners. Thank you, everyone.
Thank you, Fiona. And again, as a reminder, please put your question in the Q&A box with the presenter's name. Our last presenter is Dr. Sepideh Banava of the School of Dentistry, presenting the abstract, Disparities Exist in Domestic Violence and Head and Orofacial Injuries.
Thank you for the introduction. It's a great honor to be here to present my research study. I wanted to thank my mentors and for their contribution and also the guidance for this study, Dr. Gundolf Schenk, Dr. Sherry Libman, and Dr. Swartgansky. Sorry. So domestic violence is a serious, devastating public health issue, and one of the main reasons that survivors present at emergency department, trauma centers, and dental offices. 20 people per minute per day experience domestic violence, which is about 10 million people annually. And in the United States, 25% of women and 11% of men experience domestic violence in their lifetime. Head and orofacial injuries are primary reasons that survivors seek care, and these include head trauma, tooth fracture, jaw fracture, face, eye bruises, lip laceration, skull face, contusion, nose fracture, and these could prompt healthcare providers to investigate domestic violence. Just as a note here that based on California domestic violence and mandatory reporting law, all healthcare providers are mandated to report domestic violence if they suspect during their medical treatment or medical services that they provide for their patients. There are limited data on domestic violence-related head and orofacial injuries. A review reported a broad range of injuries, about 9 to 94%, which was different based on study location, target population. Another study in Portland, Oregon reported that 81% of about 240 domestic violence cases had maxillofacial injuries, with 69% in midface. And another study in Arkansas showed that 83% of about 1,400 domestic violence cases are women, and 50% had facial fractures. So the study aimed to evaluate characteristics of domestic violence and domestic violence-related head or facial injuries in adults in UCSF, the identified electronic health record, especially after releasing new database. So we had available data from January 1982 to June 2021. We used the Identified Clinical Data Warehouse at UCSF, which provided the identified structured EHR data. I used a research database data browser tool named Patient Explorer, which provides records of 3.6 million patients at UCSF from 1982 to 2021, and 2.8 million were for adults 18 to 89 years old. And I queried domestic violence, head and orofacial injuries with about 340 terms. This is an overview of the UCSF EHR data resources. As you can see, there are two sets of data, identified and de-identified. I work with the identified clinical data through Patient Explorer, which is a user-friendly tool without having any technical and computer science knowledge, and you can query the database. This slide shows adult patient distribution in the whole database. So you can see the age distribution and race distribution, and there were in the whole database, the data is related to 53% female, 46.2 male, about 4,000% non-binary, and 0.5% unknown. And then Hispanic 48%, 8% Hispanic, non-Hispanic 48%, 8% Hispanic, and 44% unknown. When I queried the database for domestic violence, so the results was 7,926 domestic violence cases, 99% were women. And you can see the race distribution compared to all patients. This is the graph of all patients in the whole database. You can see that white individuals were overrepresented, but at the same time, if you look at the Asian and Black African American percentages for domestic violence, we can see that the cases increase compared to the whole database. When I queried for head and orofacial injuries, at least having one injury, we can see 8,100 cases. Men had more injuries than women. You can see the race distribution here, again, the same as before. The percentages increased for Asian and Black African American cases, even though white individuals were overrepresented. And then when I queried for head and orofacial injuries frequency and gender distribution for a few years, like 2016 to 2021, you can see the distribution, and also you can see that the number of cases were, the percentage of cases were higher for women than men. And interestingly, for 2021, even though the cases decreased significantly, but the cases were higher for women. In the next step, I queried the database for domestic violence and head and orofacial injuries at the same encounter. So it means that when someone referred to a healthcare center, they were diagnosed with domestic violence and one of head or orofacial injuries. There were 146 cases, 97% were women. You can see the race distribution here. Again, Asian and Black African American had higher percentage compared to all patients in database. And patients with diagnosed head and orofacial injuries were 5 times more likely to have documented domestic violence. And I tried to query for each of those head and orofacial injuries. Because of the time constraint, I cannot include all of them here, but I just focus on tooth fracture and domestic violence. So when I queried for domestic violence and tooth fracture, out of those 146 cases, there were 21 cases for tooth fracture, and 100% were women, and Black African American were overrepresented in this group. And again, we have higher percentage for Asian individuals. And there were 2 cases of jaw fracture in this group. And lastly, when I queried for domestic violence and pregnancy in the same encounter, sadly, 2,900 women had experienced domestic violence during pregnancy. And we can see that white females were overrepresented, but again, the percentage for Black African American was higher in this group. And 17 patients experienced domestic violence and during pregnancy with tooth fracture. So in conclusion, we can see that disparities exist regarding domestic violence and orofacial injuries. Patients with head orofacial injuries were 5 times more likely to have documented domestic violence compared to patients without head orofacial injuries. Women were overrepresented for both domestic violence and head and orofacial injuries, and Black African American women had more tooth fractures incidents compared to other races. Domestic violence is an underestimated and under-researched condition for different reasons. Patients' hesitancy to report domestic violence, providers' lack of training to ask, validate, detect, and refer, or AVDR, for domestic violence survivors, and inefficient screening tools for domestic violence, such as questions that are included in the screening tools. There are some strengths and limitations of this study. So this was the first study which assessed domestic violence and head orofacial injuries from 2.8 million patient records, and with a broad list of search terms. And there are limitations, of course. Race categories should be improved in Patient Explorer. There are lack of information from unstructured data. That's why we, in our next phase of this study, we're going to query more variables. We're going to analyze unstructured data and try to evaluate other health centers' data, assess providers' perspective in domestic violence screening, and develop an EHR embedded screening tool with a head orofacial injuries component to improve AVDR process, which has been submitted as K Career Development Award application, and also plan strategies in individual, community, and system levels. I wanted to just mention that October is Domestic Violence Awareness Month. Hope we can recognize, report, and prevent it. Thank you so much for listening.
Thank you, Dr. Banava. So we'll start the questions and answers. Again, please enter your questions into the Q&A box, indicating which presenter. I'll start actually by asking one question of Dr. Banava, which is, really incredibly important and also horrifying results that you're presenting. Is there not a capture of the ethnicity, such as Hispanic, Latinx category in that database, and why is that the case, and how does that may influence what you're finding as far as the white population is concerned?
Thank you for your question. Yes, there was data about ethnicity as well. I just presented as notes because of the time, but in all of those queries, non-Hispanic had more higher percentage than Hispanic group. But we have good percentage of unknown, which is not available in database, that's why that database needs to be improved.
Great, thank you. Okay, I'm going to go to the Q&A box. So what I'll do is go through the ones that haven't been answered, and if we don't have a lot, we can go back to the one that's already been answered. From Olga Smith for Sara Zhou, are there any plans for your group to develop initiatives to reach more Black patients for CRC's colorectal cancer screening?
Yeah, thank you for the question. So at the moment, our team is very small. There's only maybe like a few people working on this outreach campaign. They've been diverted to focusing on COVID vaccine outreach. So our specific team isn't focusing on it, but in the healthcare system in general, it's been a focus of the SFHN's primary care clinics. They're actively rooming when patients get roomed for telehealth visits. they'll be sent a fit kit if they haven't been, if they're overdue for screening. So I think it's a focus of the entire healthcare system, not just not our team at the moment.
Yeah, I will also thank you, Sarah. Colorectal cancer screening is obviously a big priority for the Cancer Center at UCSF. We have a whole initiative on this called SFCAN, the San Francisco Cancer Initiative. And actually a good chunk of the colorectal cancer work is focused on community health centers and the health network. So just check it out, sfcan.org. Great. Next question from Sarah Miller. In relation to disparities in racial representation, do you think white and non-white patients are represented differently due to presenting for care differently? I'm not quite sure who that's addressed to, although it could address any of you. Sarah, if you don't mind entering if you want a particular person to answer it. Anybody want to take that one up? While we're waiting for that, why don't we just go to the next one? Fiona, can you expand on the level or types of exercise participants perform for physical activity, whether it's aerobic based, weight training, moderate level?
So from my understanding of how the survey was designed and the way that they were asking the question, it included moderate levels of exercising, so walking, jogging, biking, and dancing, and even gardening. And the prompt for the interviewer was to follow up with explaining that it should be any type of physical activity that helps improve your heart rate and leads to some level of sweating. Unfortunately, the survey did not specify specifically the type of physical activity they were engaged in.
Great. Again, Sarah Miller, if you want to clarify who you want to answer that question in the Q&A box, that would be great. I have a question, which is like an implication question for Dr. Scheuner. Given what you found, how does a healthcare system ensure that the implementation of any intervention doesn't create either expected or unexpected disparities, in your opinion?
Yeah, great question. So I can just tell you one thing that I've had the opportunity to do is present my findings to VA leadership at very high levels, including the Office of Inspector General that is doing a whole project on telehealth in VA. And so that might have some impact. And then for us in genetics and for many services in the VA, we're creating a dashboard where we're going to be collecting this kind of information about demographics of the patients that are referred and don't follow through, and just trying to track better and monitor so that we can observe differences should they happen. And then I think, really, we did, as part of this research, conduct a bunch of interviews with 55 interviews to be exact, with referring providers and also the genetics providers in VA to better understand what we are observing with this quantitative data. And that's been somewhat helpful. And next, we do plan to now speak with veterans to hear from them. So I guess in terms of how do we detect this if it's happening, I think using that dashboard will be super helpful. And then designing programs, and VA is great with working with health services research. They fund a lot of health services research and implementation research. And so I think just having this awareness that we need to make sure we're providing services to everyone and making sure all kinds of services are available, not just telehealth.
Yeah, that's great. Thank you. I will mention one thing, which is that I think typically, and it makes sense that healthcare system plan their interventions at sort of the big middle, like people who just lots of them in their system. And oftentimes that is white English speaking people and with people with education and technology access. Just seems to make sense. Like we did this with COVID vaccine, for example. But when you do that, you almost invariably create disparity. So sometimes we need to rethink that. Like maybe we should go for the big middle and actually go for the sort of the people that we know already have disparities first. That just makes more sense to me as a clinician, because you usually work with people who have higher risk factors first, not people with lower risk factors first. So just something to think about. Dr. Scheuner, I do wanted to point out the one question that you did answer, because it's an important question about regional variations in terms of VA service.
Yeah, this is a great question. That was one of the first things we looked at was, could the differences we're observing in these referral patterns to the various programs be due to differences of demographics in the populations those programs are serving? And so this took a lot of data crunching by my team, and because we had to look at like over 8 million, 9 million VA patients that were potentially touched by these 4 programs, to kind of understand the source populations, and then to look at differences between the referral population and the source populations from those communities. And you could not explain what we've observed solely on the basis of those kinds of differences. So it's a good question, and we did look at it. Thank you.
Thank you. So Sarah has come back with a question for Dr. Banava. There's a slide that mentioned white women were seen more frequently for facial injuries due to domestic violence versus Hispanic women. And so in relation to disparities in racial representation, you think white and non-white patients are represented differently?
Sure. Thank you for the question. Yes. So one thing that was, based on different queries that I have done in this database, it shows that white individuals are overrepresented, but at the same time, we have good number of unknown people that they didn't disclose the problem to be related to domestic violence, and this happened mostly for individuals in minority groups. So that's one of the issues that lead us to assess unstructured data, because sometimes, actually most of the times, clinicians try to take a note of their observations. So that could be helpful to understand patient situation and maybe patient race, ethnicity, not exact, because they might not disclose it in a structured data, but they might mention when they talk to their doctor. So that's why we have to have more information. We have to include unstructured data with structured data to have a comprehensive picture of the whole situation. But in general, based on the results, non-Hispanic individuals experience more injuries and domestic violence than Hispanic. But as I said, we have a good number of unknown ethnicities in the database.
Thank you. I have a question for Fiona. So the idea of multi-behavioral change intervention is, I'm a generalist, so I think that feels really spot on. But learning what you learned from this, what are the implications of people who design interventions that are focused simply on one issue or only on the individual patient? What do you think we have to be careful of when we do things like that? Barbara, can you mute yourself, please? Thank you.
I think one thing that could be missing when we're so focused on one behavior is missing out on the opportunity of using, for example, family members in terms of how they could be a potential part of addressing these behavior changes. So a lot of times when we see patients, for example, in the clinic, or even when we go out to a community and talk to the individual person, we forget that they live in a very complex structure, that there are both benefits as well as strengths in those connections to help address these behaviors. And also being when we are hyper-focused on one, I think a lot of the literature also mentioned that if we can address multiple behaviors at the same time, why not, versus like spending all that resource to kind of do it in silo versus channeling all the resources to focus on how all of these are really interacting with one another at the same time.
Thank you. There's a couple of questions for the domestic violence, Dr. Banava. One is, what is the protocol for provider to report instances of domestic violence when they become aware of it?
That's a very good question. So based on California law, all healthcare providers have to report immediately with phone, and then they have to get a form and try to send the report, a written report, within 2 days. There's a specific form which can be downloaded, and then based on the health center and the laws and regulation, it should be sent immediately.
Right. Yes. Thank you. We have to report it.
Yes, definitely.
And not just the bottom line is, I would suggest that not only do providers have to report it legally, I think everyone else is morally required to report it, but that's sort of my opinion on that.
Yeah, but sorry, actually just one point here, that it has been suggested in the report that healthcare providers are mandated when they provide medical services. So if someone can have a consultation session, but they don't provide any medical treatment, and they are not mandated, but that's maybe one of the issues that should be clear in the law, but healthcare providers are definitely mandated to report.
Another question. So it has to do with Dr. Carliner. Is it possible that facial injuries are more visible, so it's more likely to prompt a domestic violence screening? So how does type of injury and differences in presentation maybe seen in your data set?
So head and orofacial injuries, yes, they are visible, and but not. There are different reasons actually that healthcare providers might not report. One of them is lack of knowledge, or they might not be familiar with different orofacial injuries, specifically tooth fractures or jaw fracture. So training in this area would be really helpful for healthcare providers, so they understand that when they see various orofacial injuries, they can monitor, they can observe, and they can track it and ask for more questions from the patient. I don't know if I answered that question, but training really is needed to detect orofacial injuries.
Thank you. One question that was already answered, but I thought was important to bring out. So Fiona from Myung-Win, validation of physical activity and healthy nutrition self-reports in your study?
Yeah, thank you for the question. So I think this comes off also that because our outcome variable was double verified by the family member as well as the saliva cotinine. For both physical activity and nutrition, we did not have that verification, the double verification. It was all based on the participants themselves self-reporting. We did consider other proxy measures, such as like the use of nutrition label. Might that tell us anything about a verification for diet? Changes in weight, does that tell us anything about the behavior of physical activity or diet change? But in the end, what is decided that neither of those were truly good proxies for that. So for our study, we only had unverified for both those behaviors.
Yeah, and someone who's also done some physical activity and health and nutrition work, it's actually a difficult thing. Validation, because validation for those things take intense observation or intense reporting. And when you do that, you end up basically limiting your sample size and the kind of, your sort of research population. So it's a big giant trade-off, particularly for minority populations, which tend to not want huge research burden. So important scientific question, difficult to address practically. There's a question which I think is pretty broad, but it is about domestic violence. So I'll refer it to Dr. Banava. What about non-reported cases of domestic violence and the psychological issues that we may not see?
Yes, that's a very good point and very good question. Unfortunately, this is one of the issues that we have with the structured data, which there are some cases that might be there, but we cannot record in the structured data. That's why assessing unstructured data, clinical notes would be very useful to understand the breadth and depth of the issue. So we are hoping that in the next phase of the study, we can query more variables, for example, PTSD and psychological issues and domestic violence, but at the same time, trying to analyze clinical notes, which I had right now approved to have access to clinical notes, and then match structured data and unstructured data for patient cohorts. This could be helpful to understand which part of data was included in clinical notes, but not in structured data. Hopefully we can get more information in next study phases.
Thank you. We're coming toward the end of the Q&A. I did want to ask Sara one question, because again, I'm very fascinated by this study design of opt-in and opt-out. And I remember reading the abstract and was a little confused about what they're opting into and what they're opting out of. But it's very clear that asking patients to do something, it's harder than having them say, I don't want to do something. This is sort of my take on sort of this study design, which is great. So we tailor our provider-patient discussion, particularly the way we train our providers, is to really, give them lots of information and then ask them what they want to do, right? That's really classically a patient autonomy approach. What does this project make you think about in terms of, is that the right approach for every patient? And does that vary by culture and ethnicity?
Yeah, I think that's a really great question and I think that my initial thoughts are that patients really care about their health and they really want to follow what their doctors say, but sometimes they're just barriers that including like going into the office and going to a colonoscopy appointment. There are certain barriers such as like embarrassment and like not wanting to talk about these sensitive health issues, that having this opt-out approach removes one barrier of having the patient actively say that they need this, and instead implies that this is actually really important for maintaining their health. And so yeah, does that answer your question?
Yeah, in a way. I mean, I think obviously we're going through a lot of this with the COVID vaccine, for example. And when is that controversial? But when it's less controversial, I wonder sometimes whether, as a provider, sometimes I'll just say to the patient, okay, I'm going to give you the flu shot today. Tell me if you don't want it. Mm-hmm. As opposed to, do you want a flu shot today? I mean, it's just a very simple turning of the question. And it sometimes feels like it is not good for patient autonomy. But you have to kind of sort of think about how a person responded the way you framed the question that you're giving to the patient, right? So anyway, just really intriguing. I think your work is really starting a really important dialogue about how we teach what it means to have patient autonomy and treat patients' choice as the primary thing. So,
thank you for bringing up that point.
Yeah, so we'll stop with the question and answer. There were a bunch of questions about when these slides, so people are very interested in your work. They want to see your slides. We'll make sure that these things are available online at the diversity.ucsf.edu/HDRS website. We will try to get it up there as soon as possible. So thank you to all the presenters. We're going to now transition to the breakout session. They'll start at 10:20. We'll put you can see the links here We'll put it in the chat in a minute so you can click on it. You can also go to the online epostersonline.com/HDRS 2021 to click in on these links. There are, I think, 6 sessions, really all great stuff. Do remember to come back around 11 for our second plenary session. Actually, what Angeline wants you back here by 11:10, but come on back and we'll see you then. And after I finish talking, we'll start putting these links in the chat in case you don't have it. Thanks, everybody.
Thank you very much.
All right, everyone, let's get started on the third and last plenary session for this symposium. I want to turn it over to Dr. Monica McLemore as the moderator. Dr. McLemore?
Hello, can you hear me?
Yes.
Awesome. Welcome, everyone, and thank you so much for this exciting panel that we have that's currently scheduled. We're going to learn a lot from our message prepared students and faculty, and I'm very, very excited and looking forward to hearing from these individuals about their exciting and innovative work. First, we'll hear from Brittany Morgan, and then we will hear from Sapphire Mackenzie Sampson. And full disclosure, she happens to be a mentee of mine, and I'm really excited for the work that she's going to present. And then we'll hear from Sahir Daharia. Brittany, are you on?
Yes, I am.
Awesome, wonderful. And are you able to share your screen?
Yes, I can. Okay, so hello everyone. My name is Brittany Morgan, and today I'm going to talk about a proposed incorporation of a One Health approach to in a framework to address minority health and health disparities. I worked on this project with Dr. Feherman. We're both at the University of California, Davis. The authors on this project have no disclosures to report. So before we begin, I want to emphasize that the examples I'm going to cover in this presentation are speculative and not an assumption of causality. The goal of this project is to be hypothesis generating and to get you thinking about these topics in new and unique ways. I'll be taking a global context when discussing health disparities. And while there are many definitions for research framework, in the context of this presentation, I'm using it to mean a structure supporting collective scientific endeavors, guiding development and investigation of a research question. So a few years ago, the National Institute on Minority Health and Health Disparities developed a research framework utilizing multiple levels and domains to conceptualize the range of determinants that are relevant to minority health and health disparities research. The vertical axis lists the domains of influence, which include the biological, behavioral, physical built environment, sociocultural environment, and the healthcare system. The horizontal axis incorporates the levels of influence that are identified in the socio-ecological model. The model states that health is affected by interactions at the individual level, the interpersonal level, community level, and the societal level. So combined, the framework produces these 20 cells that reflect determinants of health disparities that span from social determinants of health to the impacts of structural racism or biological and genetic determinants. An investigator may use this framework to hypothesize determinants of interest, develop multi-level and multidimensional research studies, identify gaps in knowledge by linking each individual cells to their literature review, or to visualize how and where their research fits in the grander scheme. However, humans don't operate solely within the socio-ecological environment. Increasingly, studies are showing the association of biological, cultural, and environmental factors are important to health disparities research. So a more nuanced way of viewing health may be as a product of our human ecosystem, which combines components of the ecosystem traditionally recognized by ecologists with the built environment and social characteristics, structures, and interactions among these factors. I think the best way to demonstrate this is with an example. So my work focuses on disparities in antimicrobial resistance, and I'm going to go over a framework I filled in with determinants of AMR disparities. So under the original framework, we identified determinants such as hygiene practices and injection drug use, which is an individual and behavioral determinant, patient-clinician relationships and antibiotic prescribing practices, which is an interpersonal healthcare system determinant, as well as infectious disease prevalence within the community, a community biological determinant. However, we also know climate change impacts AMR and could influence disparities. Changes in temperature affect pathogen growth, survival, and virulence. Food scarcity leads to dietary shifts to potentially higher risk foods, and water scarcity impacts water, sanitation, and hygiene. Evidence also supports environmental determinants like the unequal distribution of pharmaceutical waste, the presence of antibiotic residues and pathogen reservoirs, and the impact of heavy metal and biocide use. Finally, humans and animals both carry bacteria, and we exchange bacteria with every contact. Manure runoff impacts only certain communities and is driven by manure management practices on farms. Food and meat production practices may dictate how often antibiotics are used and how they're used. So the question really becomes, where in this framework do these determinants fit? You can maybe make arguments some should go in certain cells that are already present, but the issue is they aren't easily incorporated in the framework as is. And we think the framework could accommodate these broader determinants by incorporating a One Health approach, which views human health as inextricably linked to animal and environmental health. And this is perfect because our human ecosystem includes interactions with both. When we talk about human and animal health linkages, in this context, we're considering all non-human species. And these connections include things like human-animal bond, food practices, the microbiome, interactions individuals have with non-human animals in the environment, as well as an individual's livelihood system. So this is particularly relevant for farm workers, people experiencing homelessness, agricultural communities, and certain racial and ethnic minorities. Human and environmental health connections include things like climate change impacts on health, environmental pollutants, and extreme weather events. These disproportionately impact poor people and populations of color, and they can drive or exacerbate health disparities. So for example, hepatocellular carcinoma disproportionately impacts Latinos. And one of its causative agents is aflatoxin, which is a mycotoxin from fungi. Aflatoxin often afflicts corn and maize products, which are dietary staples in Latin American cultures. And aflatoxin levels increase with rising temperatures and increased drought, which are driven by climate change. So aflatoxin from fungi represents the human, non-human species connection. and the influence of climate change on aflatoxin levels represents the human environmental component. So now we're going to take a look at the adaptive framework we're proposing. We're proposing the introduction of two new levels of influence, an interspecies level, which contextualizes the interplay, interconnectedness, and the interdependencies of humans and non-human species, as well as a planetary level, which contextualizes Earth's natural systems, resources, and biodiversity. So this is the same framework as before for antimicrobial resistance, except you see on the right side of the table, there are two new levels of influence that are shaded in gray, interspecies and planetary. And these levels of influence operate across all the domains of influence, same as the original levels. So if we go back to the determinants, we couldn't quite fit in the original framework. Food and meat production practices now have a space in the framework at an interspecies level, and they fall into the behavioral domain due to their modifiable nature. The global animal protein demand is in the behavioral domain as well, but at the planetary level due to its global nature. The biological impacts of climate change and the presence of antibiotic residues are included at the planetary level, as is the distribution of pathogen reservoirs in the physical built environment domain. Shared pathogenic and non-pathogenic microbes between humans and non-human species now has a cell as an interspecies biological determinant, and livestock and manure management practices are in the physical built environment domain. These could also fit in the behavioral domain. It just depends on your research question. So in this example, I considered the impact that these practices have on the physical and built environment of the surrounding areas where people live, recreate, and work. Finally, the distribution of pharmaceutical waste is a determinant in the healthcare system domain at the planetary level of influence. So combined, you can see how adding these two new levels of influence drastically expands our view of health disparities determinants. Our hope is the adaptive framework can foster multi-dimensional and multidisciplinary research projects. I want to wrap up by showing a brief example of how the framework can be used to generate hypotheses, and I'm going to use disparities in obesity for this example. So maybe you're interested in the way low socioeconomic status impacts obesity disparities through food insecurity or metabolic processes. So this is already a multidimensional and multi-level research question. However, we also know that extreme heat events disproportionately impact individuals of low socioeconomic status and can be related to food scarcity and insecurity, as well as thermogenesis. So these bottom three determinants would be identified and included in a research question using the original framework. However, the overall influence of extreme heat events is identified in the adapted framework, and it shows how this level of thinking can expand our understanding and may elucidate some of the complexities that surround disparities in obesity. So in conclusion, broadening our scope of health determinants pertinent to understanding and addressing health disparities will create new areas and avenues of inquiry, encourage multidisciplinary work, and can provide opportunities for researchers who specialize in fields other than human health to begin incorporating a health disparities lens in their work. That's all I have. Thank you.
Thank you so much, Brittany. I love that framework and I love your slides. Safa, are you ready?
Yep. Okay. There we go. So my presentation this morning is entitled Maternal Nativity and Risk of Adverse Perinatal Outcomes Among Black Women Residing in California. And this work was actually recently published in the Journal of Perinatology. And so my goal this morning is to go over this work, walk you through the project and what we found, and then also provide a bit of a sneak peek to some of my upcoming work in this space. So to ground us all in the same space right now, we know, and there are long-standing and well-documented disparities in maternal and child health in America. And when we think about this, we usually look at the differences between Black and white women. And this is apparent in California as well, when we look at the rates of preterm birth, infant mortality, and low birth weight. And we see that in each case, the Black women have a much higher risk of the outcome. And in the case of infant mortality, it's actually more than double the case. And so the majority of racial disparities research in this space usually compares Black to white or to other racial groups. And while that is the main foci, if you take Black women and you break them down and you stratify by nativity status, that is, whether they're born in the United States or foreign born, we see that there is quite a bit of heterogeneity. And so, for example, we have the work of Dr. David Howard here that I've shown, and this gives you an example of low birth weight risk. And he's stratified by maternal ancestry. And so we have different Black women, so African-born, Cuban-born, South and Central America, et cetera. And on the far right, we have white women. And so we see compared, and all of these are being compared to US-born Black women. And so we see there's this different risk of low birth weight compared to US-born Black women, depending on your country of origin. And so the majority of work, including this study, which was based in New York, has been based in the East Coast. And so cohorts have been from, Boston, New Jersey, and areas where the immigrant ethnic composition is very different from that we have on the West Coast. And so on the West Coast, we have a larger sub-Saharan African population. And in my study in particular, we found over 80% of the women who were foreign born were of African descent, with Somalia, Nigeria, and Ethiopia emerging as the top countries of origin. And so for this reason, we wanted to make our own nativity study on the West Coast using a large sample of data so that we could look at the nativity question within the context of California, where we have a different immigrant ethnic composition. So in terms of methodology, we took a population-based approach. This means that all California singleton live births to non-Hispanic Black women were included in our study who gave birth between 2011 and 2017. And we obtained this information using maternal and infant-linked hospital discharge abstracts, as well as birth and death certificates. Our exposure maternal nativity was simply dichotomized as being US-born or foreign-born. And our three adverse perinatal outcomes of interest were preterm birth, defined as birth before 37 weeks of completed gestation, small for gestational age delivery, which is being born in less than the 10th percentile for the birth weight that they're born at, and then infant mortality being defined as death before any time before their first birthday. And so for analysis, we used chi-square tests to compare the rates among the US-born and the foreign-born Black women. And we also used Poisson regression to compare the US-born women to the foreign-born women in each of these outcomes to see whether they had an elevated risk of any of the adverse outcomes. So in terms of results, we found that the proportion of adverse perinatal outcomes was much higher amongst the US-born women in each case. And we see this in very starkly for the small for gestational age births and preterm birth. I want to note for infant mortality, it was a very rare outcome in our study base. And so for that reason, it's very small in both cases. Moving on to the regression models, we had run a lot of sequential regression models, starting from a simple model in red that had adjustment for sociodemographic characteristics. And this includes maternal age at delivery, highest level of education completed, the insurance payer for the delivery, as well as their parity, so how many previous children they'd had. And we worked up to a fully adjusted model, and these are the points that are in blue here. And this model included additional clinical characteristics, including gestational diabetes and gestational hypertension, for example. And so what we found was across all of the models that included preterm birth and small for gestational age deliveries, in all of the cases, the US-born Black women had a much higher risk of these outcomes compared to the foreign-born Black women. In the context of infant mortality, however, in the model that I had first described that only adjusted for sociodemographic characteristics, we did see this elevated risk of infant mortality. However, after full adjustment for all of the characteristics, this was no longer statistically significant. And I also want to mention that the error bars for these estimates are very large, and that is because I said recently that we did not have a lot of data for this outcome. So in conclusion, we did find that the rates of adverse perinatal outcomes were much higher for the US-born Black women than the foreign-born Black women in our study, and this is for all three across the board. However, in the context of the regression models, we found that the US-born Black women had statistically significant increased risk of preterm birth and small for gestational age deliveries compared to their foreign-born counterparts. And in previous work, looking at infant mortality, they had found similar increased risks for US-born Black women, but again, I feel as though our sample size was not large enough to detect a difference. And so I would hope that replication with a larger sample may yield different numbers. And so we know, and I want to reiterate this because race is a social construct, we know that these differences between US-born and foreign-born Black women are not due to inherent genetic differences between the two. Rather, we hypothesize that this difference and disparity that we're seeing is due to differences in cumulative accumulation of racist or racial discrimination across the life course. And this exposure that US-born Black women have to particular racism in the United States elevates their risk of these adverse outcomes. And so we really would like to see future studies considering these experiences of racism across the life course, not just during pregnancy, when they explore the heterogeneity of risk of adverse perinatal outcomes by nativity among Black women. And as I said, a little sneak peek of the work that I'm currently doing will hope to explore this. And we will be looking at a national sample, not just California, and looking at the rates of mistreatment during maternity care, disrespectful care, as well as low autonomy. So these levels of discrimination, and comparing this between foreign-born and US-born Black women. And finally, I just want to acknowledge my amazing team of collaborators. I would not have been able to do this work without them. And I also want to acknowledge the California Preterm Birth Initiative for generously funding this study. Thank you so much. My email is here if you have any questions that don't come up at this time and you'd like to follow up later. Thank you.
Excellent job, Sapphire. Thank you so much. Sahar, and can you please correct me if I'm not pronouncing your name correctly, please?
Yeah, thank you. Let me go ahead and share my screen. Okay. All right, I think you should be able to see. Thank you so much, everyone. Hi, my name is Sahar Daradia. I am a recent graduate of UC Berkeley School of Public Health, where I've been working with Dr. Andres Cardenas. And today I will be sharing some of the findings from our work on the impact of prenatal and early life adversity on epigenetic age acceleration in the Chamacos cohort. So first, let's start off with some background. Epigenetics is the study of mitotically heritable changes in the activation and deactivation of genes without any change in the underlying DNA sequence of an organism. Increasing evidence has shown that environmental and lifestyle factors such as diet, smoking, and more can modulate these changes. DNA methylation is the most widely studied epigenetic process, occurring when a methyl group is added to DNA, typically at cytosine nucleotides. Stretches of cytosine guanine dinucleotides, which are known as CpG sites, often have high levels of methylation. DNA methylation has been shown to regulate gene expression, playing an important role in the onset of many diseases, as well as the overall aging process, which is the focus of our study. Epigenetic clocks harness changes in DNA methylation to predict the true biological or epigenetic age of an individual's cells, tissues, and organ systems. Several generations of clocks have been developed, each trained using the methylation of a different set of CpG sites to predict the true biological age of a specific DNA source, which is most often tissues like blood. So we used 6 distinct clocks to estimate epigenetic age in our study.
All of these clocks, with the exception of Horvat's pan-tissue clock and the skin and blood clock, were designed for adults and geared towards measuring morbidity and mortality, making them less specific for children. Biological or epigenetic aging can occur at a faster or a slower rate than chronological aging, which is based on birth date. And so epigenetic age is strongly correlated with chronological age, making these clocks highly accurate biomarkers of aging. Most epigenetic clocks are not validated in children, yet many studies have shown that exposures during growth and development can impact health outcomes later in life. Evidence has demonstrated that childhood is a critical window in establishing and modifying rates of epigenetic aging. Faster rates of biological aging or epigenetic age acceleration have been associated with all-cause mortality and morbidities like cancer, cardiovascular disease, and obesity. Understanding the factors that accelerate or slow biological aging in utero and during childhood can potentially lead to health interventions for these age-related conditions. And this leads to our main research question: does prenatal and early childhood adversity alter epigenetic age acceleration in children? So our study population was composed of a subset of the Chamacos cohort, which is a longitudinal birth cohort study of children from primarily low-income Latino farm worker communities in California's Salinas Valley. Demographic covariates and measures of prenatal and early life adversity, such as household income, poverty level, and the built environment, came from maternal and child medical records, questionnaires, and interviews. Participants in our study also consented to providing blood samples for genomic analysis, and we used these blood samples to generate DNA methylation profiles using the Illumina 450K and EPIC arrays. So with these profiles and the 6 clocks that we discussed on the previous slide, we calculated the epigenetic age of Chamacos children at 3 different time points, age 7, 9, and 14. Our main outcome for this study was epigenetic age acceleration, which we found for each participant from a linear model of epigenetic age regressed onto chronological age for each of the 6 clocks. So this figure shows the performance of all 6 clocks at 3 time points during childhood, age 7, 9, and 14. Chronological age is shown on the x-axis, and it's given in years, and DNA methylation age or epigenetic age is shown on the y-axis, also in years. So as you can see by the positive significant correlation between chronological and epigenetic age, most of the clocks performed rather well when they were applied to Chamacos children. The DNA MTL clock is rather unique because it is an indicator of telomere lengths, which are known to shorten with increased cell replications and aging, hence the negative correlation that we see here on the bottom right. The only clock that did not perform well in our study population was the pheno-age clock, so we did not include it in further analysis. Of all the prenatal and early life exposures that we looked at, maternal field work during pregnancy was associated with epigenetic age acceleration in children. So these forest plots show the point estimates and 95% confidence intervals for this association across 3 time points, with epigenetic age acceleration derived from several clocks. And you can see that compared to children of mothers who did not work during pregnancy, children of mothers who engaged in field work during pregnancy had increased epigenetic age acceleration or faster rates of biological aging at ages 7, 9, and 14. And here we define maternal field work as activities such as harvesting crops and thinning or weeding fields. These multivariate linear regression models were adjusted for potential confounders, such as maternal age at delivery, child sex, household income, maternal smoking during pregnancy, maternal adverse childhood experiences, maternal education, and marital status. The results from the DNA MTL clock were significant and consistent with what we see here, but we chose not to show them because the effect sizes were negative due to decreased telomere length, which is consistent with increased aging rates. We also looked at the association between maternal field work and intrinsic and extrinsic epigenetic age acceleration. So intrinsic epigenetic age acceleration is the residual from a multivariable regression of epigenetic age from the Horvath clock on chronological age and immune cell type proportions. So that makes this metric independent of age-related changes in blood cell composition that are associated with immune system aging. On the other hand, extrinsic epigenetic age acceleration incorporates those blood cell counts and thus is a measure of immune system aging. So compared to the literature, the effect sizes of this association are moderate to strong. For example, we can see here that maternal field work during pregnancy was associated with accelerated biological aging by 3 to 4 years for children at age 7. Maternal agricultural work during pregnancy was also significantly associated with increased epigenetic age acceleration at age 7 alone, after adjusting for the same confounders. And here we defined agricultural work as tasks that did not involve direct field work, such as working in a packing shed, nursery or greenhouse, or as a truck driver in the fields. And finally, childhood poverty, which was defined as being at or below the federal poverty line at age 7, was significantly associated with increased epigenetic age acceleration at age 7 alone, suggesting a largely cross-sectional association. And we continue to adjust for the same confounders here. So to summarize, prenatal and early life adversity, specifically maternal occupation during pregnancy and early childhood poverty, increase the rate of epigenetic aging in children at ages 7, 9, and 14. Future research should aim to identify the mechanisms by which these upstream socioeconomic factors impact early accelerated aging. The impact of altered epigenetic age acceleration during childhood on long-term disease burden also needs to be followed across time. This research on early epigenetic aging offers a biological foundation for weathering or the health effects associated with cumulative stress and adversity. This can offer new targets for public health interventions, especially for minority communities that are often disproportionately affected by these exposures. So thank you so much for listening to this talk, and thank you for this opportunity. Special thanks to my mentor, Dr. Andres Cardenas, and the other co-investigators listed here. I know we have a Q&A after this, but I've also listed my email address if there are any other questions or comments.
Congratulations to our 3 speakers. What a wonderful presentation. We do have some time for questions. It looks like we have about 13 minutes, and we actually have several questions in the Q&A box. The first question is for Brittany. Brittany, the questioner states, I'm curious if you could speak to the potential challenges that empirical investigation of planetary and ecological factors on health. Specifically, what potential strategies could be used to overcome the challenges of linking exposures that are distant and require a long latency to health outcomes?
Okay, well, thank you for the very easy question to get started. One way that I'm aware, and what I use this in my own research, so I'm going to stick with what I know, is using fixed and random effect models for multi-level and longitudinal data. So using nested data within spatial or temporal clusters can be a way to reduce biases by controlling for these conditions that are within the cluster and that might be confounders even if they're unmeasured. And so these types of models can often separate between and within cluster variation and can improve inference for investigators for some of those more complex exposures. So the framework that the NIMHD proposed, or well, they didn't propose, they published it and they have it on their website, is a multi-level and multi-dimensional framework to aid investigators and already beginning to think about their research questions and in this way. And so all we're doing is adding on an additional level to this already multi-level. So as long as you're already using like hierarchical data analyses or multi-level and longitudinal data analyses, you would just kind of add this in. But I think Really, the challenge will be more conceptual, and it'll be for researchers to move beyond analyses and research studies that are focused on linking risk factors to outcomes, and to begin thinking about these issues in a more holistic way and how health is embodied by individuals, as well as how these risk factors develop, why they're distributed the way they are, and because often they're spatially distributed. So I hope that answers the question. I'm more than happy to talk about it further.
Thank you so much. I'm going to summarize the next 3 questions that are for Sapphire, because she and I have talked a lot about these. So I'll read them verbatim, but then Sapphire, you and I have talked about many of these. So number 1, can you share a little bit more why you only included Black non-Hispanic women, and were Black Hispanic women not available in the data somehow, or are there other reasons why? That's question 1. Question 2, you mentioned that one of the reasons for increased low birth weight among US-born Black women is racism. Can you mention some other possible reasons for such adverse outcomes based on your research? And question 3, maybe I missed this, but can you speak to whether or not or how you accounted for potential heterogeneity in experiencing racism among foreign-born Black women? One could imagine that the life experience of a Black Canadian woman versus a Black African woman are different.
Okay, so we've got a lot. I'm going to jump right in. So the first question about non-Black Hispanic versus Black Hispanic women being included. Great question, first of all. And second of all, there is a very small population of these women in the data set. And so, for example, when I say US born in my context, Puerto Rican women are excluded, and US born is really only the contiguous 50 states. And it was a very small population of women. It was less than 0.01% of the women in the entire data set. And so they were excluded from this analysis, but it's a very valid question. And it has been pursued by some other researchers, in particular, Felicia Bediaco comes to mind. I think in 2016, they published a paper that looked at that specific intersection of Black Hispanic women in birth outcomes. Specifically, I think it was low birth weight. And they talk about this thing about the fact that there is such a small population. And so they found a very large data set to work with. And they found that, I think if I remember the findings correctly, that the Black Hispanic women had lower risk than the non-Hispanic Black women, but a higher risk than the Hispanic women alone. And so it seems like there is a lot there, but that is definitely not my bread and butter in this research. So I don't want to go further into that and completely discuss it because I don't have much more to say on that. I will say for the second question about other reasons besides racism, in the context of nativity, there's also been some work done by Carla DeSisto more recently in about 2018. And what their team did was looked at deconstructing the disparity in nativity using things like, hypertension or, education. And these are reasons that come up a lot, especially when you're looking at nativity work, because a lot of folks will say, well, immigrant Black women, they probably come here healthier, more educated, they're the best of the people from their, sending country. And that's why they're coming here and having better birth outcomes. And so what DeSisto's team did was look at, maternal education, which in my cohort was much higher amongst the foreign-born Black women, and said, well, how much of the disparity between these two groups of Black women is due to maternal education? And it was about 10%. They did the same thing again, looking at gestational hypertension. One thing that comes up a lot is, this idea of diet and that, the foreign-born women haven't acculturated to the American diet. And so maybe they're just healthier. And so they looked at hypertension, gestational diabetes, and again, it was between 5 and 15%. And so we have over 80% of this disparity that isn't explained by these typical clinical or, demographic factors that we would think make the most sense. And so that's why I really feel like racism, which hasn't really been dug into deeply, really is a more important factor to consider. One of my colleagues at USC, Dr. Parker Dominguez, has done some recent work looking at this nativity question with foreign-born and US-born Black women in the context of interpersonal discrimination. And her findings were that across the life course, foreign-born Black women experience less discrimination. However, if you immigrate here younger, so under the age of 18, and you've lived here most of your life, your outcomes are more similar to that of a Black woman who was born in the United States. And so this is why I say it speaks to the specific experience of discrimination in America, because the longer you're here, the more you experience it. So that was kind of a bit of question 2 and 3, specifically about, I think it was epigenetics and like the long lastingness of the effects of nativity. And if I understand this correctly, the question's a bit about this intergenerational difference. And there is some research actually just recently that came out in 2020 that asked about whether or not the foreign-born women who come here and have lower rates, do their children have lower rates compared to US-born folks? And it turns out that they do not, that it does not sustain throughout the generations. And so that's something else to look into, but it does seem that this foreign-born advantage, if you would call it that, does not persist beyond generations. And so I feel like one of the things going forward would be to look at is how staying in the United States, you experience this kind of racism over time, and it changes not only your life, but the life of your children as well. And I feel like I covered the 3 questions, but
let me cut in one more time, because I do have 2 questions for Sahar, and I don't want us to run out of time.
Yes, jump in, please.
The third question was really about the heterogeneity of the Black experience. So a Black Canadian woman might have a different experience than Black African women. So can you really quickly speak to whether or not you accounted for any of the heterogeneity within the foreign-born Black people who were in the study?
So thank you for reminding me of that part of the question. I definitely forgot it. So in that context, no, we did not include that in this current study. I do have a forthcoming study that really does drill down a country by country analysis of the foreign-born Black women in California. So that's coming out soon. And in addition to that, I would just say that I do agree that, you know, Black Canadian versus Black African, Black Caribbean, there's very different experiences, not only here, but in the home country, when you think about whether they are a majority or minority group. And that's also going to impact their level of discrimination and, you know, class discrimination, you know, social strata. There's a lot that's going to be different depending on the community that you're sent from. And so that is why I want to do this breakdown analysis going country by country, and that's coming out soon. So keep an eye out for it.
Thank you, Sapphire. Sahar, there was 2 questions for you. We had in our last 5 minutes. If we don't get to the next question for Brittany, please make sure you look in the chat, because there is an additional question that's been added. Sahar, the first question is, can you explain the linkage between epigenetic age acceleration and actual lifespan or quality of life? It's super interesting that your findings suggest that biological aging at different points of human development, but I would love to know if there are any impacts that are long lasting. And then the second question is, did you measure the time it took in declining of telomere length and telomere numbers or other similar biological markers to understand epigenetic age acceleration in all 3 age categories? And did you think such early accelerated aging was influenced by other factors?
Yeah, those are really great questions. Thank you for those. So to address the first one, most epigenetic aging studies have been done with adult cohorts. And these studies have shown that epigenetic age acceleration, or that faster rate of biological aging, is associated with all-cause mortality and morbidities like cancer and obesity. But research on epigenetic aging in early life and childhood has only recently been studied. So these childhood studies have demonstrated associations between stressors in childhood and faster rates of biological aging. So exposure to neighborhood violence, discrimination, low familial support have all been associated with these faster rates of epigenetic aging in children. I know that environmental conditions during childhood, like parental smoking and indoor particulate matter absorbance, even conditions in the fetal environment, such as maternal smoking and alcohol consumption during pregnancy, have been associated with epigenetic age acceleration in children. So there really is a need for these longitudinal studies to be designed to investigate whether the associations of our study and these other emerging studies in children remain steadfast through late childhood and adolescence all the way into adulthood. So that's definitely a need, and I think it'd be great to design and work on a longitudinal study like that. To address the second question about telomere length and other aging biomarkers, we did not study those. I know that other studies have shown that telomere length and epigenetic clock estimates are actually independent predictors of chronological age and mortality risk. And several studies have also shown that these clocks are actually a far more accurate predictor of chronological age than telomere length. So that's something that we did not study. But would be interesting to compare to the clocks.
And then this second part of that question is, do you think early accelerated aging was influenced by other factors?
Yeah, so there are, several factors that we did not look at, but we did look at, many other factors related to demographics, things like BMI and weight gain. We didn't see an association with those. I know other studies have found associations, but that really shows the need to do more of these epigenetic studies in children to see if those associations can be replicated with those other factors.
Thank you very much. I want to thank all of our presenters, A, for staying on time, B, for having such intriguing and fascinating studies and results. Definitely our science in maternal child health is very, very bright given your presentations for today. Thank you so much for putting your work forward. And I'm just very, very grateful to have had the opportunity to moderate this panel and to be here with you all today. Tung, am I passing it back to you?
Yes, thank you, Monica. We are waiting for Dr. Alicia Fernandez to come on to do the closing. In the meantime, I appreciate those of you who have stuck around to the end of this. It's been really a great symposium. Thank you to all the presenters and all of your work as well. So just wanted to check if Dr. Fernandez is on yet. It looks like she's trying to get on. So if you don't mind holding on for a minute.
Tung, I wanted to let you know another question came up in the chat around the link for the survey. So this might be a good opportunity to plug for people to do the post-symposium survey.
Oh, yes. Thank you. I hope you all will take the time out to give us feedback. We do this every year and we always get really good feedback for next year. So we just so you know, we try to balance all the different kinds of sciences, all the different populations, all the different schools. This is the first year actually that we've done it virtually. So obviously we would love to have your feedback on everything so that we can improve the processes. As I said yesterday, I hope maybe next year we'll all be together in person. But if not, and we're back to virtual, we want to make it a better experience for you. So please take 5 minutes out when you do get that email and reward us by answering it. Thank you. It looks like Dr. Fernandez might not be able to come on. And I'm wondering whether Assistant Vice Chancellor Rincon would be willing to do the closing.
Yes, Tong, happy to do it. Let me get myself up here. Thank you all for joining us today. This was such a wonderful set of presentations. So my apologies that Dr. Fernandez is not able to join us. But again, we hope you all have enjoyed this wonderful forum. This, I think, has been incredible in many respects. We've heard from so many wonderful presentations on various topics on the issue of health disparities, whether factors impacting healthcare for non-binary patients, structural and historical factors impacting vaccination within Black communities, tobacco cessation for Chinese and Vietnamese patients, and prenatal services for women in the Salinas Valley. It all has been wonderful and very informing. As Chancellor Hoggett pointed in his welcoming remarks, racism is a determinant of health disparities. Indeed, COVID-19 rubber stamped the role of racism in patients of color, with a disproportionate number of deaths in the United States happening within communities of color, particularly African American and Latinx. We were honored to have Dr. Kamara Jones deliver the keynote address in her role as the 2021 to 22 UCSF Presidential Chair, and given her anti-racism collaborative framework, she has been instrumental in supporting UCSF current anti-racism initiative and its pillar focus on advancing health equity. After 14 years, the Health Disparities Research Symposium is now an institutionalized effort made possible by a group of dedicated faculty and staff. We want to thank again all of you, and obviously, certainly our office and the staff in our office, Andrew and Rivera, again, for bringing us together to discuss these critical issues. We continue our work in the Office of Diversity to institutionalize equity, inclusion, health equity, and racial justice for students, faculty, staff, and the large communities we serve. Thank you again to all of you for joining us today. Dr. Wang, for all of your masterful, stewardship of this great event, and Andrew for being really behind the scenes, making sure that everything worked. It was a wonderful event. Thank you all.